Welcome everyone to today's webinar. We are going to be talking about innovative strategies to increase PrEP reach and accessibility. Please note that we are recording today and we will have time for Q&A at the end. We encourage you to use the Q&A box or the chat to ask your questions at any time, but we will hold off on answering questions until the Q&A portion once we've gone through all of the presentations. So today we're going to be hearing from three speakers who are going to be talking about various PrEP implementation strategies within their jurisdictions. Today's webinar is brought to you by RAISE and NASTAD. RAISE and NASTAD are partnering on the RAISE Hub, which is the Research Alliance and Implementation Science to End HIV Hub. This is an NIH-funded initiative and is a part of the University of Washington's Fred Hutch Center for AIDS Research. If you're not familiar with NASTAD, we are a national nonprofit association of public health officials who work in state and local public health departments. And NASTAD is currently the national technical assistance provider through CDC's PS 240020 for capacity building assistance for health departments under Component A. We also provide technical assistance through our HRSA Systems Coordination Technical Assistance Provider funding. We encourage you to reach out to us if you have any questions about how RAISE can support your EHE implementation efforts. And I will put in some links in the chat briefly. Today our speakers are Chase Cannon, who is the Assistant Professor in the Department of Medicine in the Division of Allergy and Infectious Diseases at the University of Washington. Dr. Cannon is also the Medical Director for the Public Health Seattle and King County Sexual Health Clinic. We also have Maria Lopez, who's the Director of Pharmacy at Mission Wellness and is also a consultant with the San Francisco Department of Health's Capacity Building Assistance Program. And finally, we have Jan Mandani, who is a TelePrEP coordinator in the STI, HIV, and HCV program at the Louisiana Department of Health. Okay, I'm going to stop sharing now, and I will pass it off to Dr. Cannon to start us off.
Okay, great. Thank you, Krupa. This looks okay to everyone. Great. Okay. Good morning, afternoon, everyone. Welcome. So I will be talking from a public health, sexual health clinic perspective about this idea of de-medicalized PrEP care, and we'll get into exactly what that means in just a moment. So these are my disclosures. And to just start with some background, I think many of you who are attending this webinar probably are familiar with the fact that PrEP is highly effective, but we know that in the United States, not enough people are using it who really need to be using it. And so the data you're seeing on the right side are from CDC that show the last time this was analyzed, only about 36% of people who had a PrEP indication were prescribed it. And it really behooves all of us to think about each opportunity where we're interacting with people and health systems to kind of seize that to prescribe PrEP, or at least, talk about it and offer it to people. And so sexual health clinic attendees that are coming in for STI screening, for talking about prevention strategies and other sexual health care are really kind of a prime population for us to target PrEP. So what's some of the rationale for why PrEP delivery specifically through sexual health clinics is important? So often these clinics are funded with local, state, federal public health dollars and really might be the best place for people to seek care if they have insured or under-resourced status. And also we're seeing people who are at risk for and being diagnosed with STI, and we know that that is associated with risk for HIV acquisition. So this is a prime population for targeting HIV prevention. And there seems to be high interest in PrEP from several studies that have been done across the years. And staff that are in sexual health clinics also have expertise and familiar with talking about these topics and are aware of the different resources that are available. And also just in terms of the opportunity, whenever we have people in our hands, we should really take advantage of that because whenever we can integrate PrEP into that care and give those referrals to people and actually give them medications in hand, that sort of reduces the loss to follow-up that we can see sometimes when people are sent externally and are told to follow up outside of the clinic. So even though, it's a prime location for that, there's a lot of barriers that I think are common across settings. And so one of them is kind of how we sustain PrEP uptake and care. And really, we're limited by staffing and budget. And on the right side, you can see over the years that public health funding has remained fairly flat and has not increased proportionally with the cost of providing services and the amount of demand that we have. And when we have high patient volumes as well, it can be hard to weave in comprehensive counseling about PrEP by clinical providers. And so it's a challenge to make sure that we're offering this to every person that comes in who might have a PrEP indication. And then last is sort of a patient perspective on this. There's been talk about whether having monitoring every 3 months is too much. So these are generally people who aren't sick, aren't taking other medications, who are healthy, and so they may not be inclined to want to come in every 3 months for PrEP. So this brings about this idea of sort of demedicalizing PrEP care, and this has come about over time in our clinic in Public Health Seattle King County, with iterations that basically our staff have helped us sort of design, and then also data-driven by what we're seeing in terms of risk for HIV acquisition among populations. So in 2014, we only had a sort of select group of people that we offered this to. And over time, we sort of expanded it to other groups that we knew to be at risk for HIV acquisition in our jurisdiction. And in 2018, sort of response to a HIV outbreak that we saw. And then moving forward to us expanding it to all men who have sex with men and transgender patients in 2020. And then in 2023, some of our staff sort of brought about this idea that we're really seeing fall off in those 1 month checks after people are initiated on PrEP, and so we rethought whether that was even something we needed to do, and so we dropped that 1 month check-in in 2022, and then since then have been extending our visits, so not doing quarterly, but doing either every 4 months or every 6 months, depending on the person and what's going on. So this is just an overview of our kind of model of what we call de-medicalized PrEP. So specifically what we're talking about here, these are DIS that are trained to lead PrEP care, and they serve as our PrEP coordinators and navigators. So they have several non-clinical duties, and that includes educating the patients about PrEP. They perform sexual health counseling, and they do phlebotomy as well for blood draws, and then assist with all the scheduling. They help with insurance enrollment and navigation for PrEP resources to fund PrEP and its care. And then they also are able to communicate with patients and troubleshoot any issues that they have. And as well, some of them are able to also help with research studies related to PrEP patients. So as I mentioned, we have extended our follow-ups to every 4 to 6 months, depending on the person, just to allow there to be a little more flexibility and convenience for our patients. And we're also not requiring our patients to see clinical providers at each visit. So now, unless they have an acute concern for an STI, they only need to check in with our clinical providers every year. And we also have the ability to do walk-in same-day starts where we actually give people the medication in hand so they don't have to go to another pharmacy to get started. They can take their first pill as they're walking out the door. So since we have done this, we've seen an incredible increase in the number of PrEP initiations. So in 2014, we had only about 20, and this has increased to over 560 in 2023. But we still have challenges, as I think a lot of people do, with retaining our patients on PrEP. So we're looking at about a 56% retention rate the last time that we evaluated this at 12 months, which is not great, but I think, we are thinking about ways that we can increase this, especially for people who have sort of higher risk, specifically MSM who use meth, and then certain MSM of color and those who are of younger age. So one way that we thought about doing this was sort of further demedicalizing things by moving our PrEP monitoring and care outside of the clinic into the home. And so we performed a pilot study in 2020 and 2021 where we gave people the option to have these devices that they could self-collect blood specimens at home. And we looked at whether this was feasible and acceptable to people and found that that was the case. Almost 90% of people said that they were interested in doing this, and that about half felt that this could increase their likelihood of staying on PrEP. And they felt this was a replicable sort of model that they could use if they were offered that in our clinic. So based on that pilot information, we went forward and initiated a larger sort of randomized trial where we are randomizing our PrEP patients to the option to have their ability to do monitoring from home with self-collected samples and telehealth follow-up, which you'll hear a little bit more about later, versus continuing their standard care coming into the clinic. And so far, we've enrolled about 340 people. So we're at about 75% of our target enrollment. And you can see there on the left side of the table that people have opted for doing this home testing, or what we call sample, self-collection and then testing in our lab and returning kits, which is great. So it seems to be that there is interest in this. And even if everyone doesn't use it, it's an option for some people to make their PrEP care a little simpler and more convenient. So just to summarize, and I'm happy to talk more about any of the things that I discussed here in the Q&A period, but I want to make sure we have enough time for everyone to speak. Demedicalizing PrEP care in the sense of having DIS lead this and task shifting is something that can bring PrEP to scale in these populations that are high priority. And that comes without sacrificing quality of care. So people still are receiving quality guideline-driven PrEP care even through this model. So you can use DIS as the coordinators, and that can really reduce the amount of clinician time that you need to conduct the visits. And we need to evaluate this in our program, but I think it could be a cost-effective way for public health programs to administer PrEP to patients at scale. And part of this is also sort of decreasing the burden that's on the patients. So requiring fewer monitoring visits for them, I think, is a good thing, just generally speaking. And in our experience with this trial, we've seen that home-based PrEP monitoring is something feasible to implement. It's acceptable, and we think it could further expand PrEP clinical capacity. So stay tuned. We hope to have sort of results from the trial after we finish enrollment and have people followed up through 18 to 20 months, and we'll see whether this impacts retention for our patients or not. So I just want to acknowledge all of the staff that do this incredible work in our clinic, including our DIS that you see listed there. And we recently had a public health associate from CDC that joined us to do PrEP work, as well as our study team and all of the clinicians and staff that make this work possible. So I will stop sharing my screen here and turn it over to our next speaker.
Perfect, thank you. Everyone, my name is Jan Mandani. I am the TelePrEP coordinator here at the Louisiana TelePrEP program. I've been a part of the program since early 2020. And I can go ahead and get started. So TelePrEP, our program is a statewide virtual provider program for insured individuals in Louisiana. We help provide access to navigation, medical appointments, and mail prescriptions for PrEP and PEP for anybody who's a resident of Louisiana. Our program is fully virtual, so we do not have any kind of clinic that anybody can come to. So we utilize emailing, texting, phone calls, and a video conferencing system to be able to communicate with our patients. Our program is a really great fit for individuals who would like fast access to PrEP without having to go to a doctor's office or who are unable to go to a doctor's office local to them. We also work really well for people who want their medication mailed directly to them. Once again, this is for people who either are not able to pick it up close to them or who do not have a pharmacy that's easily accessible for them. And we also work best for people who live in rural areas in Louisiana who may not have a PrEP provider available to them. And how our program works, our enrollment process is fairly easy. We utilize REDCap as our landing page, where our individuals who are referred to us will fill out their enrollment forms. It's mainly just to collect demographical information as well as have them sign our consent form so they can receive clinical services from our provider. Once they fill that out, then our navigator will set them up for an appointment with our provider, which usually happens between 2 to 3 days after they're referred to us and they complete their consent form. Usually can also happen the same day, depending on the patient's capacity to be able to meet with the provider. And once they meet with the provider, they get more clinical background about PrEP and how it works, or if they have any specific questions, the provider can answer for them. And then they're usually sent to go get their base labs done, either at a lab testing site like LabCorp or Quest nearby, or if a patient does not live near either of those places, we do utilize molecular as an at-home test kit that we're able to send off to our patients, depending on their needs. And once those lab results come back, barring any complications, then our provider will go ahead and write a prescription for our patients, and that gets them started on a 90-day prescription. We do have individuals who are referred to us who have recently gotten an HIV negative test. So as long as within 7 business days or 7 days from their appointment with our provider can go ahead and get them started with a 1 month prescription of PrEP. And then they have that month to go ahead and get the rest of their labs done so they can continue getting the remainder of their prescriptions. So like I said earlier, it can take as little as 1 day or the same day that they referred to us. And sometimes it can take up to 2 to 3 weeks. It just kind of depends on the patient's capacity to move through our enrollment process. And some of the things that our program does to make it easier for our patients is that we do provide education and counseling. Our navigators trained to provide guidance in determining PrEP use, answer any questions the patient may have, or at least initial questions the patient may have about the medication, HIV in general, or insurance, if that's something that they're not familiar with. Our navigator also provides insurance and pharmaceutical navigation assistance. They make it so that it's seamless for the patient to be able to see the provider and get their prescription sent or filled and sent, depending on which pharmacy they needed to use. We also provide check-in every 3 months to make sure that the patient has completed their labs, just to follow up with them and kind of do like a little gentle reminder that, hey, if you haven't done your labs yet, to continue getting the medication, we just have to get it done. And that usually prompts them to go ahead and get it completed. The entire process can be done at home on the patient's own time, and that's usually because we are virtual. They can literally take a call from anywhere that they're at, and we can mail them an at-home test kit if they don't have a lab testing site near them or unable to go to them. And also the pharmacy that we use mails, like all of our medication is mailed out to our patients unless they needed to pick it up from a local pharmacy or depending on what their health insurance dictates for them to do with their prescriptions. We understand that though this program is very useful for many people, there are some individuals who may not benefit as much for a telehealth version of PrEP services. So for those individuals, we do refer them to local and in-person PrEP services as close to them as that we can get them possible. And I kind of mentioned earlier that our program is initially for people who have health insurance in Louisiana. However, not everybody does have access to that. So we work with any referrals to come to us who might be uninsured, and we give them navigational support to either obtain Medicaid, Medicare, or Marketplace insurance, whichever one it is that they're eligible for or could qualify for. And then, let's see. And that's kind of essentially how our program works. It's the services that we provide for our patients. I just wanted to give you a quick snapshot into our program and the things that we've done. In 2020, or actually I'll start off with this. The program's technically been going on since April of 2018. But those were like starting years and I wasn't able to be there to speak on that. However, in about 2020, 2021, we hovered between 35 to 45 monthly active members in our program, which is quite low. We really had a hard time being able to promote telehealth at the time to people, even as the pandemic had happened. I guess a lot of Louisianans may just have like a little apprehension about that. But as the years went on, we were able to luckily increase the capacity. In 2022, we had some staffing changes and we're able to add a second navigator to the program, and that's helped us increase our capacity for who we're able to take in for our referrals. And then, so we went from averaging between 35 to 45 individuals for active members. We went up to 60 and 85, which was a huge change for us. We're grateful for it. And then in the last 2 years, we were able to increase our capacity even more and average about 90 to 100 individuals as our monthly active members. So then in 2024, we had a total of 252 individuals who were referred to us throughout the year. And when we finished the year, we had 101 members on the program, active members in the program. Our provider was able to write 490 prescriptions to all of the individuals who were enrolled into our program. And 204 of those prescriptions were for individuals who were newly enrolled in 2024. So now they were just referred to us this year. The number of prescriptions, the total number of people who received prescriptions in 2024 is 133 people. And of those 133 people, 72 of them were new enrollees in 2024. So those are some of the numbers about our program. And even with all the work that we're doing, we do still have some current program goals. But before I go into that, just wanted to mention that our program, we are a state, or the state program for telehealth, and we are able to work with our parish health units for our referrals. A parish health unit is essentially the parish is like essentially accounting. We just call them parish here in Louisiana. But our program works directly with our parish health units who are not necessarily able to provide PrEP prescriptions or are not able to provide PrEP services. So we share a medical, what's it called, our EMR with them. And because of that, whenever they make referrals to PrEP, we could easily do it because the information is already there. So anybody who's getting an STI testing or any STI services at our parish health units, they are then, it's part of their protocol to also ask about PrEP or TelePrEP. And whoever says yes to it, they can easily refer to them in the EMR, and we could easily follow up with them the same day. We also, because what's it called? Sorry. About 40% of all of our referrals actually come from our parish health units, which is why we work as close with them as we can. The rest of our referrals come from online searches, advertising, and merch giveaways, and also word of mouth from friends and family, and also other TelePrEP participants. I help provide quarterly training and presentations at our parish health units nurse intensive training program. That's usually for new hires every quarter. So we provide training and make sure that as many people are familiar with our program and can work with us should they need to. And then we also work close with our DIS and our community health workers throughout the different regions in our state. While they're working in the field, they can make referrals to us or follow up with us, and we can follow up with the patients. We also partner with various organizations throughout the state. Some of them already have an in-person PrEP services, but do not have a telehealth version. So those organizations we work with, they can either refer to us or we refer to them, whichever works best. And something that we make an effort to do is that we try to table anywhere and everywhere. We, of course, will go to like any health fair events that we have, but some unconventional places that we've gone to that previously we were not able to table at or provide kind of information to, or any church-sponsored health fair. A lot of churches around Louisiana, or at least around New Orleans, have recently started to promote health fair for individuals attending their congregation. And so being able to go there and provide information about STIs and HIV prevention has been very helpful for us. We've also tried to join different resource fairs for different things in our state. One of them is a service industry resource fair that happened in New Orleans a couple of times last year. We were able to attend and provide services and information for those individuals. We also try to utilize our merchandise in very specific ways so that we can make sure that we're kind of getting the most out of them. One of the things that we've done in the past is that if you're familiar with New Orleans, we have a lot of festivals and parties in our city and throughout the state. And because of that, we were able to utilize coasters that have our information in the front and our contact information in the back. And we gave them out to local bars in the French Quarter and other areas of the city so they can utilize them during these events and have people who are in the city be able to see them and kind of get the information should they need to. We also recently were able to go to a school fair for our back to school fair for children in the fall. And that way we were able to, the children, of course, like 18 or under, but we were able to speak with their parents and other prominent community figures and just give them information about PrEP and HIV prevention, just so we can reach as many people as we can. But even though with all those things that we've done, we still have these two current goals, which is increase reach in rural parts of Louisiana, and also to provide uninsured individuals access to PrEP and PEP at no cost. Due to varying reasons I'm sure we're all familiar with, stigma and misinformation in rural areas, or lack of information and access to resources has been a huge challenge for individuals who are interested in PrEP or who could best benefit for PrEP. And so we are always working to make sure that we are able to reach out to the rural parts of our state and to provide them services, or at least try to address the challenges that they are facing in terms of being able to access services. Our patients have told us that the top 3 reasons that they are interested in PrEP or TelePrEP is for the convenience, and that could be a variety of different reasons. For privacy, this one, I think, kind of plays a larger role than we might be aware of. But especially in rural places where there's limited resources, maybe there's only one clinic that provides STI or HIV services. If it's a small town and somebody's cousin's boyfriend or girlfriend, or their sister's boyfriend or girlfriend, somebody that they know works there, people are less likely to go and receive services, even if they want it or need it, just out of fear of stigma or being talked about. So I think that's part of the reason that people really come to us, is for privacy. And then also less in-person visits. This is also very helpful for people who have conflicting schedule, who are not able to go to the doctor's office either during regular work hours. A lot of people that live in Louisiana also work offshore. And so sometimes their work schedule is like 2 weeks offshore, 2 weeks back on land, or like 3 weeks offshore, and then like come back into town. And we work well with those individuals to be able to meet with them and get them their labs and get them their medication before they go off to work offshore for a couple of weeks at a time. And also for people who don't have access to reliable transportation, to be able to go back and forth. Our program also works well with them, and we work with to be able to provide services for those individuals. The other thing that has been a goal for like the last several years is to be able to provide uninsured individuals with access to PrEP and PEP. And initially, we were not able to do that just because you did have to have health insurance because of all the cost. But because our program is a revenue generating program, we were able to start in 2023 to be able to pilot a program to help our patients whose insurance might change often, either because of employment or for whatever other reason. They'll either go from being insured to uninsured to insured again. To keep them from kind of falling through the cracks and not being able to access services, we were able to kind of like as an as needed basis provide coverage in the interim for those individuals. Just to make sure that they can kind of stay on track. And then as of the end of 2024, we were able to have 14 people in our program who, for whatever reason, either do not have access to health insurance, or are not eligible to get health insurance, or are kind of in between health insurance coverages, to make sure that they can have access to PEP or PrEP with our program. And I believe that's all I have for that.
Good morning or afternoon, wherever you are. So I believe I was already introduced, and I will move to the next slide. The San Francisco Department of Public Health houses the getSFcba Capacity Building Assistance, which is funded by the Centers for Disease Prevention and Control within San Francisco Department of Public Health. And our expertise and work is for HIV prevention. Expertise is listed here, and one of them I just want to highlight is providing technical assistance to public health departments and eligible entities in pharmacy-based services. To learn more or to request TA, you can go to the website or email directly. So Mission Well, I'm going to be talking about the collaboration between Mission Wellness Pharmacy and the San Francisco Department of Public Health. And Mission Wellness Pharmacy is a community-based pharmacy in San Francisco's Mission District, which is historically the Hispanic Latino, as the CDC refers, or Latinx district of San Francisco. That has a high historical proportion of HL persons living in San Francisco. The community-based pharmacy, it's been in San Francisco since 1978. And we implemented a collaborative practice agreement with the SFDPH in 2018. It was and is a multi-division collaboration with the Pharmacy Public Health Department, Getting to Zero, and the Hep C Consortium, among other many other community-based organizations within San Francisco. It really started in 2016 when we began hepatitis C testing, and the hepatitis C testing really began as part of an initiative under the End Hep C initiative that San Francisco launched a couple years earlier to end the hepatitis C epidemic, and was born out of the University of California, San Francisco School of Pharmacy study to include a community-based pharmacy in hepatitis C testing. So we launched that in 2016 and subsequently published that study. The following year, in 2017, after launching our hepatitis C program, we added HIV and STI testing in a community-based pharmacy. And again, this is done in collaboration or work with the San Francisco Department of Public Health. In 2018, we launched the collaborative practice agreement. So it was a multi-year implementation. And the collaborative practice agreement is between the lead pharmacist at Mission Wellness and the lead San Francisco Department of Public Health physician in the STI division. That was Dr. Stephanie Cohen. The collaborative practice, which is are legal in all states in the US, in California, pharmacists are allowed to practice under collaborative practice. And so this allowed our pharmacists to provide assessments, order tests, as well as prescribe PrEP and PEP medication for HIV prevention. The program was launched as a one-stop PrEP program where patients could visit, test, and pick up. Subsequently, in 2019, Senator Wiener from San Francisco introduced SB 159, which was a landmark legislation in the United States to permit pharmacists to prescribe PrEP and PEP in California. And then in 2024, that bill was updated to SB 339 and replaced SB 159. The original bill did have limitations, only allowed 60 days. The subsequent bill allows ongoing days of prescribing PrEP, as well as, allows all pharmacists to provide PrEP for 90 days, and provided that they can meet the CDC guidelines and conduct follow-up and testing, they can provide ongoing PrEP. The original bill also mandated payment from the Medicaid program in California and prohibited prior authorizations. The subsequent bill expanded beyond Medicaid to private insurances. There are still some limits with employer-based plans, but expanded payment and also called out reimbursement for laboratory tests that were ordered by a pharmacist for PrEP and PEP. And this expanded bill was really due to limitations from the first bill that were found through several surveys in California of pharmacists. This slide here just shows some of the results we published of our testing from 2017 to 2018, the 1 year prior to our PrEP program, where we were just providing HIV. We focused on patients who were getting HIV tested, even though we were providing STI and hepatitis C testing. I just want to point out a few. Again, this is only part of a slide of the data, but a couple differences. Almost 20% were female, where our PrEP population we see less than 5% female. But in terms of race and ethnicity, those numbers are pretty close, 52 and 17% for Hispanic, Latino, and Black African American. And the other thing that's notable is that a majority of patients did not have a primary care provider, 57%. Almost half of patients that were getting testing at the pharmacy, 47%, had not heard of PrEP. And that's notable because San Francisco has had a huge campaign for PrEP. But again, these are patients coming to the pharmacy. And the final thing I want to point out is that a large majority, 81%, did approve of pharmacy-based PrEP. We also published an implementation paper that goes into the details of our implementation for the collaborative practice. And in that paper, we presented the results of the first year. So 51 patients were initiated on PrEP and 6 patients on PEP. 47% identified as Hispanic or Latino, 10% were Black. Hispanic Latino make up about 15% of San Francisco demographics and Black about 5%. So we are reaching the populations that are targeted. Our program was really supported by the health department because, like we see in many parts of the country, San Francisco does have health inequities in reaching persons who identify as Hispanic, Latino, or Latinx. We also found that 60% received medication assistance, meaning that they didn't have insurance to cover their medication. Some of the successes that we have seen from our program are the ease, obviously, for patients, that they can go to one location to visit, test, and pick up the medication all within the one visit. We're also collaborating with the local health department for these services to reach priority populations, and that's probably, was one of the aims of this program and one of the big advantages. Given that we've had a collaborative practice the entire time, even though there's been state law, we haven't had to wait for legislation, so we've been able to provide ongoing PrEP throughout the period. In 2018, when we implemented the program, our pharmacists, from the very beginning, have been able to provide ongoing PrEP. And then I think an added bonus is that the staff really enjoy the expanded services, and this certainly helps us with recruitment and retention, particularly among pharmacists. Some of the challenges that we have seen have been just in implementing or updating a collaborative practice with the health department. It takes a really long time. Things are very slow, and that's sort of what the literature shows when there's protocols for pharmacists with public health agencies, because the agencies move really slow, move especially slow compared to what a private industry timeline typically is. For example, for the initial implementation, the city attorneys in San Francisco took 20 months to approve and sign off on the collaborative practice so that it could be signed by the physician and leadership. The other big challenge for us has been reimbursement. Reimbursement has been very slow. There is a model in Washington State where they had reimbursement language that was passed in 2015. And so 9 years later, we've expanded our reimbursement legislation, but it still has not caught up. And we, in fact, have not billed to date. Part of that has to do with our original collaborative practice not permitting us to bill because city attorneys would not sign off on that. I do want to point out that that is just that, with, I guess, with the COVID pandemic, for example, it is a little bit different because with the COVID pandemic, we were provided vaccines through the federal government that went to states, and we were allowed to bill for vaccines, but it's more of a local decision on that part for us to bill. And it's one of those things where the cart before the horse, because without financial reimbursement, it's really hard to grow a program and to staff it. So we've been really challenged in staffing our program, both for pharmacists when we are low on pharmacists due to illness or vacation, or having somebody to draw blood, whether it's a nurse or a phlebotomist on site. And the pandemic was particularly difficult for us. Community pharmacies were really tasked with providing vaccines for the COVID pandemic and testing, which we got involved in. And so that also really pulled with our staffing challenges. In terms of the next steps, we have a new CPA. It's with an outside prescriber, and we are in the process of implementing it for injectable PrEP. So we will be providing injectable PrEP, adding that on, as well as doxy-PEP. And then because we're using an outside provider, we can bill for services. Additionally, as one of the first sites to provide PrEP and PEP in California, we have been funded for a couple of studies, and so we're currently involved in studies both with our site and other sites across California. And all the studies are around injectable PrEP. So I just wanted to give an overview of our program and really allow for questions at the end. And just remind you that if you have additional questions or need TA specifically on pharmacy-based services or any of the areas that are here, you can reach out to the getSFcba.
Great, thank you so much. So I think we can now move on to the Q&A portion of the call. So there's a few questions in the chat as well as in the Q&A box. So I'm going to go ahead and just kind of go in order. And some of the questions have been answered by our speakers. So I will just point you to those. One of the questions here, I think this is going to be for Chase. This question is DIS activities and folks balance between deal received from the DIS with this additional.
I think we lost you for a few seconds, but were you asking about the DIS question in the chat?
Oh, I'm so sorry. Yes. What has been the feedback from DIS in terms of taking on this additional work?
Yeah, so we our county and our model is sort of a little different in that we have DIS that obviously can sort of do various activities, but we generally have them focused on sort of one or a couple of bodies of work. So we have two of the PrEP DIS that are specific to PrEP care, so that's like their full-time job. And then we've got a couple that sort of split their time between like syphilis partner services or other activities as needed and PrEP. And so I think for the ones that are full-time doing PrEP, this works out well for them and they enjoy being able to just focus on that activity. We do know that sometimes it can get a little challenging, especially if the cases start backing up for syphilis, for those who are sort of maybe doing the partner services part like 1 day a week and then the other 4 days a week. It can be hard to keep up with the workload. And so that's a challenge that we have to work through. But generally speaking, the ones who are doing it full time have felt that it works well for them. And it's nice for them to just focus on that only.
Great, thank you. And I guess I can ask a similar question to Jan and Maria. Have you all, what has been the experience in terms of getting buy-in from staff and from leadership with your programs? Sorry, can you all hear me?
I could hear you, Krupa. I don't know if
Okay.
Jan and Maria want to answer that, but a question around staff buy-in for your programs and satisfaction, capacity, that kind of question.
I mean, I can go a little bit. So initially the grant that they requested was, I guess, for like a specific, it was for a specific amount, and it was easy for our management to be able to, I guess, like go along with it or support it because it had a model of utilizing the grant first and then using 340B revenue for it. And also because we are kind of utilizing a lot of our state's pre-existing either platforms that we're using, programs, and other resources, it was fairly easy for us to kind of create the program and work that way. So that's one of like the benefits of that. But in terms of buy-in, it's also fairly easy to be able to implement either our protocols or referral protocols with different organizations. So we're very lucky that it's kind of worked out in that way. In terms of like capacity and also In the beginning, though, it was kind of hard to be able to increase our staff capacity just because things just seem to be a little bit easier to work with. But I cannot express enough how even adding a second navigator to our program had made huge differences in our capacity to be able to do more outreach and process more referrals to our program.
I would say that buy-in from the organization, given that I am the leader of the organization, that part has been not an issue. More so, I would say buy-in, from public health organizations and agencies, really around funding. I think the pharmacies really the industry faces as a whole a lot of challenges given the insurance industry. There's a lot in the media about payment for pharmacy. So the industry is struggling with that reimbursement. And given the limited resources that we have in public health, I think that is probably our biggest challenge in terms of getting buy-in and really showing that, demonstrating that pharmacists can do this work. Pharmacists have done work in other areas, and really the literature, does support pharmacist-based PrEP. And so it's really more of a public health sort of buy-in that we have to work on as a profession in pharmacy.
Great, thank you. Matt, I see your hand up.
Yeah, I had a question for all you guys in a way. Given that the numbers of people we need to put on PrEP to have a meaningful impact is measured probably in hundreds and thousands, not tens. What kind of numbers do you think we need to see to really call these kinds of programs successes?
If anybody wants to go for it, maybe I can start. I mean, I think it really depends on sort of the scope of the focus. So like if you're sort of working at the state level, I think obviously those numbers are quite different than if you're working at the local level. It is important, I think, also to sort of when we're talking about all these interventions, be looking at the next step. So, is this going to be cost effective? How can we scale things up? What sort of funding do we need to keep these programs sustainable? Or is there a place that we can sort of say, is this not working and we need to divert resources to something else and sort of pivot? And so for our program, at least, that is something that we try to think about from the beginning is, looking at cost. And that was a question that was in the Q&A. Because cost effectiveness and sort of the time that it takes for staff is an important resource, and so wanting to make sure that we evaluate that before we make a decision is going to be important before we commit to scaling up. So I don't know that I have a specific number in mind, but I think those two metrics are important to inform that decision about whether to move forward or not.
Yeah, I think numbers are kind of hard to really defined by a site because, depending on what their reach is and their capability, based on financial to make it effective. We have a site in Washington that has publicly said they provided over 700 PrEP patients. I think now they're at 1,000. And I know at our site we probably have provided several hundred. We don't have an exact number because we haven't analyzed that yet. Again, because of focus on the pandemic. But so that's what I wanted to say about that. I don't know if anybody else wants to talk about the question for numbers. I did see there was another question in the chat, but I'll let Jan respond to the first question.
Yeah, well, thank you for that question. I do think it's important for our state. So like our numbers, like I said, had grown over the years, though it's not necessarily maybe the capacity that we are needing, especially for a high prevalence state that we are. However, the numbers that have changed have made a huge impact in terms of the education that people in our state have been getting in regards to PrEP. We do have a lot of people who are referred to us who are honestly mainly inquiry and like kind of ask about what PrEP is. And then we have some of those people come back and reach out to us again in a couple of months and say, hey, I think this is something that's of interest to me, or like this sounds like something I want to be a part of. So at least I feel like I can speak mainly for like state of Louisiana. We are addressing the challenges of health literacy and also insurance literacy in our state. And so for us to be able to make these strides in numbers, I think is fairly good. But as per usual, of course, like we can also make more. And our goal is to be able to do that. We're also not the only telehealth or teleprep program that's available in our state. So we do work with other organizations who have the same thing. And because we are the state, we're not necessarily, I guess, like in a way competing with other people for that. Our main goal is that anybody who wants access to PrEP or PEP gets access to that, whether it's through us or through a different organization in our state. So we also kind of work as like a support for other organizations if that is the case. But yes, I do think that like the numbers, it kind of depends on the background of the jurisdiction that you're in, but I agree with what also Dr. Cannon and Maria said.
Okay, our next question, I think this is for Maria. How are pharmacists reimbursed for their time and effort for the pharmacy-initiated PrEP program?
Yeah, so as I mentioned in our program, we are not billing currently. We do plan to bill based on the legislation. Again, the Washington model, which has published and presented the most data on PrEP since they've been able to bill for almost 10 years now, they were able to show at 9 months that it was financially feasible to provide PrEP and PEP. California's law for private insurances mandates that reimbursement is at this 100% of physician rate, and then 80%, 85% for Medicaid patients. And there is a question in the chat, about the lab results. So I did want to, they said, the question is how pharmacies outside of a CPA, how they've operationalized obtaining and interpreting lab results. So prior to SB 159 in 2019, pharmacists have been able to order laboratory tests for therapy. And so through that legislation that was prior, pharmacists could order tests and interpret them. In pharmacy school, all pharmacists are trained on ordering and interpreting tests. It is limited training. What we found is that when we implemented our program, our health department actually trained us to a basic competency. And subsequently from there, we have been training pharmacists in California. And I put up in the chat 2 training programs. The CDC offers free training, as well as the American Pharmacists Association, which I was part of to help create that training for the American Pharmacists Association. The APHA has traditionally provided training for postgraduate pharmacists, and that is the most common route for pharmacists who already have a degree to be trained, besides being trained while they're in pharmacy school. So, we can interpret the test. We just need to have probably additional refreshers if we haven't done it in a while.
And then this question, I think, Maria, you may have already answered this, but for the health department, will they be able to bill for services in the future, or will the pharmacist be able to bill for services?
Our pharmacists will bill for services. So we're technically permitted now to bill. We just we just got everything signed in December. So we're in the process of implementing the new CPA with injectable PrEP and billing, as well as DoxyPEP added to services. And so we'll have to bill, we suspect in California, since the law just passed last year, in talking with my colleagues across the state who are also rolling out pharmacy-based PrEP, nobody has been able to successfully bill just yet, but it is a process. We have to get credentialed. The insurance plans are now mandated to pay. They do have to, though, credential pharmacists so that we can bill and receive payment. Very similar to the way it was in Washington State.
Great. Okay, I'm not seeing any other questions. Any final thoughts or comments from our presenters? All right. Well, thank you all so much for joining today and for this great conversation. Thank you to all of our speakers for sharing about your wonderful work. Our next webinar will be in mid to late February, so look out for the announcement for that. We'll be focusing on long-acting injectable ART for that webinar. Thank you all so much. We'll see you next time.